So what is sepsis? So sepsis occurs when a natural response that our body does to fight off infections actually goes system-wide and it causes system-wide inflammation. So your body fights infection on a small scale is a good thing. But once it starts going throughout your whole body and starts to work on organs, you get into multi-organ failure. It does more damage than good. It dilates and it just causes a wide stream inflammation.
And that's the biggest thing where your body kind of, it's fighting a war and unfortunately caused so much damage that it's like irreversible temporarily, right? And your body releases white cells, it attacks it. When that bacteria dies off during the infection, it creates something that our body vasodilates. And that's like the biggest thing we have with sepsis for those that are not in the hospital is blood pressure issues where their blood vessels are they're so dilated. There's a pump, which is the heart, and there's not enough volume. The pipes are all dry. So the blood pressure goes down. And how does the pump respond? It keeps working faster. That's why our heart rate goes up, right? One of the sepsis criteria. So we're fighting this infection. What we do is we put them on life support medications called like pressors, right? And we squeeze vasoconstrict to help those pipes get smaller so the pump works less, difficult. And eventually, when we can't save the patient, the sepsis is so bad, the pipes are so dilated, there's so much fluid we could give him, and the pump just gives out, which is the heart, which goes into crazy rhythms. We shock them out. Sometimes the heart goes asystole, where you stop breathing, stop living, and we just pump you and crack your chest till, you come back alive. And or somebody tells us to stop. And that's the crazy part of sepsis. So I just took you, as cool little anatomy field trip. If you're talking about the magic school bus, we jumped into the heart, explain how that worked. And it's sad, but that's why we have the sepsis protocol, which we're going to talk about. And that's how we kind of get patients to prevent that from happening.
Yeah. And there's different stages of sepsis, but there are related to bacteremia. And the two most common, issues that cause severe sepsis or septic shock are pneumonia and peritonitis that develop into a wide bloodstream infection. And there's these few bacteria that are more prevalent that are related to septic shock and severe sepsis. And those are MRSA, Staphylococcus aureus, E. coli, Klebsiella pneumoniae, Enterobacter species, and P. I don't know how to even say this one, man. P. Aeruginosa. And those are, if you go to the hospital, majority is our elderly population, and you have pneumonia, then you become septic, and you're infected with like MRSA, you have a higher chance of not coming out of the hospital alive, just because it's a more serious blood infection. And it sucks because it does happen to our elderly population and affect them. What makes it even worse is they're already immunocompromised in the first place, and they have a weaker immune system, and they have less resilience. That's why they're the ones that suffer the most with sepsis, and that's usually the number one killer of our elderly population in hospitals that come to the ICUs and things like that. That's why we're so pumped, or I guess that's why they push us so much on preventing collapses, preventing like Matt said, UTIs, preventing, catheter-associated UTIs, CAUTIs. And so we're so strong on this because we know that if somebody gets septic and they go to severe sepsis, their chance of walking out of the hospital are very slim.
Not only that, but if the government is aware of this, they don't pay reimbursements to hospitals. And we talked about this before. And that's why the government is basically saying, you know what, guys, if we put a Foley in and you guys cause an infection, that's a hospital-acquired infection. We ain't paying, let's just say 20% reimbursement on this patient now. So now the hospital takes a hit. You don't get your raise this year. That's why they're crazy about it. But it's also crazy, PD, is that you have a patient that comes in for a simple procedure. Let's just say they get their appendix removed. They get a small little procedure. I'm trying to think of what kind of small procedures are like day surgery. But let's just say it goes.
Pleural effusion. You get pleural effusion.
Okay. Yeah, perfect. Small little procedures, day in, day out. But you have to stay in the hospital one day. Sometimes it gets complicated to stay 2-3 days. The longer you stay, sometimes they get pneumonia. They get that. Sometimes people come in for something small and never make it out of the hospital. Like that's just something crazy to think about. And that could be your family member.
It's very crazy to think about. Like Matt said, you go for a small procedure and then bang, like you're in the hospital, you get pneumonia. That's why, I don't know, man. It's when you become older, it really sucks. Like it sucks when you're old because you're not as resilient. Your body is not a fully tuned machine like you were in your 20s, 30s, 40s, 50s. Once you start getting past those 60s, 70s, 80s, you're getting up there, and it's a lot harder for us to treat these things because these issues, when they evolve, they get worse fast and they get worse quick because there's no resilience. Like your body is already, weak as it is, and it does suck. And then there's actually 3 stages of sepsis. There's SIRS with a present infection, then there's severe sepsis, and then there's septic shock. Septic shock, man, if you go to septic shock, it's a really high mortality rate. I think that's the number one killer of hospitals is sepsis and especially septic shock. Like once you have sepsis, we do everything in our power to prevent you going from to severe sepsis and septic shock. That's why there's so much protocols in place to catch it. There's so much protocols in place when you do develop sepsis.
And one crazy thing about sepsis and why it's such a high mortality rate is there's something called organ dysfunction begins. So every single organ, the body is so fine-tuned, it has multiple organs, and every single one regulates a specific thing. You have the kidneys, and if those go bad, because that's one thing, you have lack of blood flow, the kidneys shut down. What happens when the kidneys shut down? You have a backup of fluid. You're not extracting uric acid, different things, different pH imbalances that the kidneys are in charge of. So now we have to give you medications to correct the pH. And now we have to do dialysis because your kidneys are giving out. You have fluid overload. Your lungs can't work properly on the ventilator because you're fluid overloaded. Lasix, there's no need to give them because your kidneys aren't working. And those are the complications that we deal with sepsis sometimes. It just creates a cascade of different things. And then organ dysfunction just complicates everything else on top of fighting the actual infection. And a lot of families don't understand this. And they're like, well, he was just fine 3 days ago. He just went to go get breakfast with Sally. Well, yeah, it's crazy. 3 days ago, he was walkie-talkie with a cane, and like shit hits the fan so damn quick that, yeah, right now he's on life support and he needs dialysis because organ dysfunction. But yeah, we could talk about, I feel like just thinking about this like blows my mind how like a quick shit how it takes over so quick. And like, yeah, man, people die and we see it normally more, and we're more like we're less affected by it, to be honest, because we see it so much. But yeah, this happens on a daily basis.
It's crazy to think about how on a small scale, it's good because you're fighting off infection. But once it affects the whole system, it's a horrible event to be in. So like Matt said, let's touch upon these stages of sepsis. The first one is going to be SIRS, which is your systematic inflammatory response with a present infection. So for you to be considered sepsis, you got to have 2 SIRS criteria and some kind of infection. So your blood cultures come back positive. You have a wound that's positive for some kind of a growth. And then SIRS could be any one of these things. So it could be an elevated elevated body temperature, less than 36 or higher than 38. So it could be either hypothermic or hyperthermic. You have a heart rate above 90 beats per minute. And that happens because your body needs more cardiac output. So one way to increase the blood flow to your organs is to increase the heart rate, which is naturally you're going to pump faster. So obviously you're going to get out more blood. Another one is tachypnea. So that's a high respiratory rate. Anything above 20 is going to be considered a high respiratory rate. And you actually, since you're breathing so much, you're actually breathing out a lot of CO2. So a lot of times it's either going to be a high respiratory rate or your ABG, your CO2 on your ABG is going to be less than 32. So you're alkalotic, respiratory alkalosis. Why? Because you need more oxygen in your blood. So your natural response is to breathe quicker. You blow out the CO2 and you breathe in more O2. Another criteria is an increase in WBCs or low WBCs. So anywhere between 4 and 12 is normal. If you go below 4, that's SIRS. Or if you go above 12, that's also SIRS. And just remember, you got to have 2 of these. So 2 out of these 4 plus some kind of infection documented. So is it a wound? Is it a surgical site? Is it your cultures came back positive? And it's a scary thing. So that's why I'm not sure how they do it in your hospital, but in ours, if someone's is in SIRS, we get notification. So if someone has tachypnea, elevated heart rate, WBCs are dysfunctional, their CO2 is low, there's a little window that pops up for us and shows, hey, you have SIRS going on. Is there also an infection? Are they in sepsis? So it kind of notifies you to kind of take a look at the whole picture if there's something else going on. But it pops up for us a lot, even though they don't have an infection, is because most people that I work with are in heart failure or a cardiogenic shock, because cardiogenic shock produces this similar responses, but without the positive bloodstream infection or without the positive culture sites.
Yeah, so you have positive lactic acids. So taking a step back really quick for those that are non-healthcare, because some people are just tuning in and listening to us, what PD went over is basically the SIRS criteria. It's us kind of grading you to see whether you're at risk for sepsis. And what happens is if you potentially are, we're going to draw some urine on you. We're going to check your blood to make sure you don't have any infections. And we'll normally give you an antibiotic right away, just because broad spectrum, because we're trying to prevent what we kind of just stated at the beginning, systemic organ failure. And what usually happens is we draw lactic acid. If it's greater than 2.0, normal hospitals, we should give you fluids. And there's a sepsis fluid bundle. We usually give 30 mLs per kg, right?
Yes.
Okay. And that's a plus and a minus, because those that are healthcare, you know those patients, you have a 95-year-old grandma with a bad heart and you want to dump her with a freaking 2,000 mLs of fluids. She's going to, in 2 days, go into fluid overload. We have to treat her with Lasix. So the fluid bundle.
What was that, dude? Someone shooting at you.
Yeah, I feel like the gate, man. My Amazon package came in. So anyways, what happens is we give you the fluids and we're trying to prevent this organ dysfunction. Like I talked about, not enough volume in the pipes to help the pump. So it's preventative. So yes, sepsis, we're trying to prevent sepsis, but we also could complicate the patients on different things, especially those with heart issues that can't handle all that extra volume.
Could have said it better myself, Matthew.
I love this episode, man. We're just going into like deep, like nursing, anatomy, physiology. I kind of fuck with this. Yeah. If you guys like more of this, how we kind of talk about the human body, let us know. And on Instagram, Facebook, or wherever, we'll give you guys more of like the nitty gritty science.
That's correct. All right, guys. So the stage 2 of sepsis, if you get out of stage 1 and we didn't treat you enough, you're now in stage 2. So stage 2 is severe sepsis. This is the SIRS criteria plus some kind of bloodstream infection or a wound infection or some kind of infection in your body, plus some type of organ dysfunction. That could be a drop in urine output. That could be altered mental status, decrease in platelet count, difficulty breathing. Now you're short of breath. Now we got to intubate you. Abdominal pain. Maybe your cardiac numbers aren't looking good. Maybe your troponins are up. Maybe your D-dimer is up. Maybe your cardiac indexes, cardiac outputs are way below your normal threshold. Maybe you're hypertensive. Maybe you're hypoperfusing. Now you're in severe sepsis. And this is when stuff turns to, starts to go real bad. And then what comes next is stage 3, which is septic shock.
Hold on, PD.
Yes.
So before you get into stage 3, I kind of want to talk about one thing, which is sudden changes in the mental state. As I'm not an experienced nurse, but I know some shit, let's just say. One thing for let's just say we talk about sundown and we talk about confused patients. In stage 2, sometimes that 60-year-old guy is going to become confused and that's why neuro assessments is good. Always check and beginning your shift, the year, and they know where they are. Because if they're confused at 12 o'clock, hey, I understand maybe that 80-year-old grandma is confused. Maybe you are giving her Ativan to go to sleep or melatonin. What if she's confused because she's going into potentially organ dysfunction and severe sepsis? If of course, there's already things to be, if she's at risk for. Maybe you need an ABG. Maybe her CO2 is getting elevated and you just freaking snowed her with Ativan. And now we're going to delay treatment for another 4 hours because she's knocked out, So yeah, that's one thing I noticed that we missed in the hospital. We're like, oh shit. Yeah, she wasn't confused. She was going into septic shock. But anyway, stage 3 PD, let's hit it.
So stage 3, septic shock. And what's crazy about septic shock, what I learned is that if somebody is in septic shock or they go to septic shock from severe sepsis, their mortality rate is 30 to 50%. So you have a 50% chance of not walking out of the hospital alive once you reach septic shock. That's why it's so important for us to not have our patients go into this issue. And septic shock is defined something as hypotension despite fluid resuscitation. So we got to give you sorry about that. So now we got to give you pressors. So if we give you fluids, which should ideally increase your blood pressure because now you got more volume. It's not working. Something's going on. And now we need, like Matt said, pressures. Now maybe we need to give you levo. Maybe you're on levo. And you also have elevated lactic levels, which are going to trend further on. So, but it's crazy. So once you go into septic shock, your chance of walking out is 50%. Your mortality goes so high up, and that's crazy. That's so unfortunate, and that's just how the cascade works. And it sucks, man. Like I've seen people develop it before, and it's just a sad thing. When, like Matt said before, somebody in their 50s, 40s, or whatever, just had breakfast yesterday, and now he's here in the hospital in septic shock because he's been septic at home, but he has been refusing to go to the hospital or get checked out, and then they come when they're in severe sepsis, when things are already kind of at the end of the line.
So I'm going to share something it's a very personal story, and it's crazy because I, as a nurse, felt powerlessness because the truth wasn't told. And if the truth when the truth is not told, it sucks, And this is a story about a patient that went into septic shock, and he went into full blown on ARDS, which is a very one of the complications of septic shock, that your lungs are just not working. And the family didn't understand why this happened to him at such an early age because he was in his 50s. And there was 3 sisters and very religious family. They're Muslim. There was a rabbi, a lot of, how the Muslim culture is.
Yeah.
Okay. One of the sisters only knew that he had HIV. No one else knew that he had HIV. And the sister said, because she was a power of attorney, no one else can know. So we as nurses knew why he is not progressing, why he's not getting better, where they're inserting an A-line. Now they're taking for a procedure. Now they are starting dialysis. He's on CRT. He was pronated. Why is nothing working? And only one sister knew why, because he was immunocompromised because of HIV, but the other family didn't know. They're praying, and it's like, we can't tell them the truth because that's just part of nursing. You have those families that are like not dysfunctional, but there's just stuff that's not told, And I almost wanted to, I'm explaining to a family member, like why we're trying everything. And it's like, they have HIV, but I can't tell you. And it's fucked up, But yeah, man, that's just one case that like reminds me of septic shock. That I'm like, whoa, dude. I had him 3 days in a row. And imagine what kind of mental exhaustion I felt, where I'm dealing with this family every day. They're saying hi, they're smiling and they're laughing. But hey, now he's in ARDS. And yes, we have to prone him, and they don't understand why this is happening. But yeah.
Unfortunately, that's one of the downfalls of religion. As much as beneficial as religion is, this is kind of the things that kind of lead to sometimes, because I'm sure if you tell them that he has HIV, they're gonna assume what? The same thing that everyone typically assumes is that they got it from unprotected sex, probably with another guy or whatever the stereotypes are for HIV nowadays. And that's kind of how people are going to think. Even my parents would think the same thing if I told them, or if I died and somebody said that I have HIV, they'll probably think it's the worst thing in the world. Like, what did I do with my life? I was probably doing heroin, doing all these drugs, having all this unprotected sex. And they're going to judge you for it. And some religions believe that if you do these things, you're a sinner, and there's no way for you to go to heaven. So if you kind of think about it, you can kind of understand why the son didn't want, or the gentleman didn't want, daughter or whoever didn't want that to be known that they have HIV, or at that point, I'm sure it was AIDS. It's understandable, and it's kind of sucks because maybe if they knew, it would have given some closure, but maybe it wouldn't have. Maybe it just would have. Maybe his family would have shunned him. Maybe they would have not given him a proper funeral. Maybe they would have talked crap about him on his deathbed. You never know, and that kind of sucks. That's how certain cultures, have a visual or have an idea of this disease that you just can't disclose, unfortunately, because you get so much bias and so much hate about it.
I get it. So it's almost for his own good, for even the family's consciousness, that it wasn't disclosed. So yeah, I respect that to a certain degree. So yeah, at the end of the day, I can't judge it. That's just what happened. And I believe that the best decisions were made in care. You know what I mean?